I'd like to thank Dr. Sparias for the kind invitation. It's a case when TAVI in a failed bioprosthetic valve and left atrial appendage occlusion. It's a 75-year-old male patient with heart failure, with reduced ejection fraction of 30%. He has a coronary artery disease with a bypass surgery 10 years ago with 2 grafts, SAVI with trifecta 23 and ascending aorta replacement with graft. 5 years ago, CRTD was implanted because of heart failure, and he's a diabetic patient with CKD and GFR of 45 and paroxysmal atrial fibrillation. He came to us because of severe symptomatic aortic stenosis, NYHA3, and in the last 8 months, he had 2 episodes of GI bleeding on apixaban therapy without pathological findings in the endoscopy and computer tomography of the abdomen. In the imaging assessment, you can see the reduced ejection fraction, degenerated aortic valve with mild regurgitation and severe aortic stenosis with mean gradient of 43. In the coronary angiogram, we can see 2-vessel disease with total occlusion of the LAD and the right coronary artery at the end of the proximal part, and 2 patent grafts, Lima to the LAD and the vein graft in the right coronary artery. In the CT, the TAVI CT, we can see it generated trifecta 23 with a true ID of 20.5 millimeter and adequate femoral vessels. The annulus, the average diameter was 19.2, and we can see that there are large sinus of Valsalva and STJ, and the high of STJ was 35 millimeters, something important for the implantation. Regarding the valve to coronary distance, and is important the valve to left main distance was 9 millimeters, and the patient was type 2A. There is no risk of coronary obstruction, and there is no need of coronary protection during the TAVI. This is the angiographic views, and the femoral access was good, with good diameters and without calcifications at the common femoral arteries. The surgical risk of the patient was very high. It's a high surgical risk patient with Euroscore 2 of 16.78, and there are other factors except of the Euroscore that favor the TAVI as a valve-in-valve procedure, was that is a redo procedure, and the transfemoral approach was feasible for this patient. And we have a patient with severe symptomatic aortic stenosis and 2 episodes of GI bleeding. The CHA2DS2-VASc score was 6, and he's also a high bleeding risk patient with HAS-BLED of 3 and 2 episodes of prior bleeding. And at the heart team, the decision was to treat the patient with transcatheter TAVI and left atrial appendage occlusion in the same session. There are data in the literature for combined procedure, TAVI and LA occlusion in the same procedure. There is a trial, WATCH-TAVI trial, which showed us that the combined procedure was non-inferior versus the TAVI and medical therapy. The procedural strategy was, first of all, we did the procedure under general anesthesia, echo-guided puncture of the common femoral arteries and the right femoral vein. We pre-dilated the valve, which was a supraannular self-expanding valve. And after the TAVI, we did the echo-guided transeptal puncture, and we did the LA occlusion with a Watchman Flex device. We chose Accurate Prime 23. The target depth of the implantation was 1 to 2 millimeters. This is very important. We pre-dilated with a 20 balloon, and the vessel closure was with 2 proglides. And the depth of the implantation is very important because in order to achieve the best hemodynamic result in this patient, we have to implant an Accurate with an upper crown above the bioprosthetic valve. Okay, we predilate the valve with 20 balloon, and after this, we implant the valve at the target depth of 1 millimeter, and we post-dilate it with a 20 millimeter balloon, with the same balloon. The hemodynamic result was very nice with peak-to-peak gradient of 10 millimeter mercury, and in the TOE, we can show that there is no paravalvular leak. After the TAVI, we control again the left atrial appendage. There is no clot. We measure the length, the diameter of the appendage was 18.1 millimeter, and it is for the best option was a Watchman Flex device of 24 millimeter. After the transeptal puncture, we insert a pigtail in the left atrial appendage, and then we implant the device. We check for the stability of the device, and in the TOE, we control that there's no leak and the position was stable. And at the end of the procedure, we see that the compression of the device was almost 25%, and it was acceptable. Acceptable compression was between 10 and 30%. And this is the post-procedural assessment 4 days later without paravalvular leak and the mean gradient in the TTE of 11. As a conclusion, I can say that the combined procedure of TAVI and LA occlusion seems to be feasible and effective. And I can say that the disadvantages of the combined procedure was the fluoroscopy time, the amount of contrast, and the greater use of general anesthesia. And here are all the participants of the procedure. And thank you very much.
A very nice case. Congratulations, showing that the combination can work and we can offer solution to the patient, that it can solve not one but 2 problems. A comment from Dr. Zacharoulis, maybe?
Congratulations, Stamatis. I wonder how we choose this kind of valve.
Okay.
Can you
we have a small annuli. It's a valve-in-valve procedure. We need a supraannular valve in order to achieve a better hemodynamic result, and we chose the Accurate valve. Evolut would be also a choice, but the reason is that we need a supraannular valve.
And which was the antithrombotic treatment post-procedure?
Okay, this is the most difficult question. We chose to give to the patient NOAC for 45 days, as in the same treatment with Watchtower trial, and then single antiplateral therapy.
Of course, congratulations. I think it was a wonderfully performed procedure and very well thought case to present, because I think you actually showed us that you can have the best of 2 worlds in the cath lab. You can have your aortic valve treated, and also you can have your anticoagulation problem dealt with in one session, which is actually wonderful. I believe that as time progresses and we're getting more bolder and bolder in doing more difficult and complicated cases, I think it's going to be more and more often issues that we're going to have to be dealing in the cath lab. And what you showed us is that it's feasible, and I think that that's what we should keep in mind, that you can do all in one session, which is wonderful. Congratulations.
Thank you.
Dr. Pavas, do you have a comment?
Bravo, Stamati. Both cases involved trifecta structural valve deterioration. Trifecta was a highly promising valve, which did not meet the expectations finally. And I think that both cases highlight the importance of the first surgical aortic valve replacement with regard to the lifetime management of these patients. I think it's of imperative importance for the cardiac surgeon to avoid small valves, to perform aortic root enlargement, and to use a TAVI-friendly surgical valve, valve that can be fractured or at least remodeled, and a standard valve with interiorly mounted leaflets. Thank you.
Yeah.
If I don't know if someone from the audience has any comment. Thank you, everybody.
I think, Mr. Chairman, that is very important, the existence of heart team in a hospital. This, I think, is the meaning of this table. I think it's very important. I think, Dr. Sparias, thank you for your invitation here to present cath lab of the Evangelismos Hospital. Thanks a lot.